Hello and welcome to the Surgical Spirit podcast. I'm your host, Dr. Haidar Al-Hakim, the Third Eye Doctor. Pull up a chair and get ready for some candid and uncompromising discussion with experts, innovators, agitators, and influential people from every corner of health and well-being. From inside the hospital to at home in the kitchen, we're leaving no stone unturned in our quest to uncover the secrets of healthier, happier, more successful, and less stressful lives. Thank you so much for joining us, and without further ado, let's meet this episode's guest. Hello, this is Dr. Haidar, and some of you are watching here, and that's great. And when I say here, I mean the video. And some of you are listening on the audio, and that's great as well. So for you who are listening on the audio, please visit our YouTube channel because people are watching us here. Dr. Haidar. Hello, Suhail. How are you?
Hi, Haidar. How are you doing?
Very well, thank you. Very well. Thank you for inviting us to your place.
My pleasure.
Nice office, and you've got this. What's this here? What's that?
This is from Pakistan. It's a litter in which I believe the bride is traditionally carried on the day of the wedding. So.
A litter. What's a litter?
Like the Romans used to carry it.
Is that what it's called? Litter.
Yeah, I think so. Yes.
Wow.
Yeah.
All right.
So I didn't do that.
But it's very small. I mean, it's about 10 centimeters by 10 centimeters.
Yeah.
It's probably a 16th of the actual size.
Yes, this is Hussain behind the camera who's talking. So yeah, guys, if you're listening to this on the podcast, please watch us on video. How long have you been a GP now, Suhail?
GP 13 years.
Wow.
Qualified almost 20 years now from
Wow.
medical school. Yeah.
How's it going?
Yeah, it's good. It's good. I think medicine's changed a lot.
Yeah.
So I don't do the traditional GP thing. I do lots of little bits and pieces. They're called nowadays portfolio GP.
Yeah. And that just gives you scope to essentially have some time doing other things.
Yeah, like this as well.
Yeah. Exactly. Having certain opinions about things, and I think the first time we met, it was a religious occasion, and religion plays a big part in both of our lives.
Yeah.
And it plays a big part in healthcare here in the UK.
Absolutely. Yeah.
So I'm surprised that religion doesn't come into the medical curriculum.
I think there is a move towards that, at least bringing in spirituality and an understanding that patients, particularly at the end of their life, perhaps turn to that, even if they haven't been religious during their life. They understand that their end is near, and they sort of search for something greater.
Yeah. I was just thinking that patients who are vulnerable human beings tend to turn to something greater than themselves, and even I guess they turn to us as doctors, as in we have all the answers.
Yeah.
And isn't it? I mean, I find it easier when I say, well, actually, if they do have a religion, they can always turn to their religion.
Yeah.
As a form of comfort, as a form of answers, even.
Yeah. I mean, it's not something that I actively do in my consultations because I think that's a shame. I think we've become a bit sanitized from that. In having learned medicine here in the Western world, in the UK, it's become part of something else. So it's not something I address even with Muslim patients unless they actively bring it up with me. But I think, yes, there is a source of solace, a sort of, something they can turn to when they're having a hard time, whether it's illness or social or psychological.
Yeah, I mean, when I was practicing in Iraq, I was practicing for nearly 4 years. It was part and parcel of the consultation there.
Yeah.
It was absolutely normal. We talk about prayers. I pray for them, they pray for me.
Yeah.
And during the year there are different occasions, and that always came up as part of the medical consultation, and even part of if you're going to operate or do surgery, it had to be not within those religious occasions.
Yeah.
And given society, particularly here in the UK, is multicultural and multi-religious.
Yes.
I think that's something that probably the authorities, the GMC, the BMA, the medical hierarchy. I mean, it's an interesting topic, I think.
It is. I wouldn't rely upon them to instill any of that into the curriculum or into the medicine. I think they're pretty useless, to be honest.
Wow. Yeah. Well, I guess we've got to start from the grassroots.
Yeah, I think that's the best.
So, colleges and medical schools, particularly in these areas. I mean, I qualified at Barts in London, which is Whitechapel, essentially. And it's literally, you hear the adhan, every day.
Every day, yeah.
And you're in clinic and so on. And it's quite interesting because we have a lot of Bengalis there, and pain always came up.
Yeah.
Sort of, they have these sort of complex pains, and there's this term, isn't it, about sort of Asians that have complex.
Yeah. So this is something that I think we don't address or we don't tackle. It's these lazy stereotypes that doctors have about ethnic minority patients, whether they're born and bred in the UK or they're from abroad, or particularly immigrants who are a particularly vulnerable group. So there's this thing that I was reading about complex regional pain syndrome, which in and of itself is extremely complicated to A, diagnose, and B, manage and deal with. So there's a stereotype called the Mrs. Bibi or the Mrs. Begum syndrome. Now, Bibi and Begum are common Asian or Pakistani names. And the perception is that these ladies, these elderly, often brown Asian ladies, complain too much, and they have a different perception of pain. And there's nothing clinically wrong with them. There's no objective findings. There's nothing that we can do for them. But we're quite happy, or doctors, I should say, are quite happy to label them as patients who complain, who don't have anything wrong with them. They are hard to manage. They're a drain on our resources. They're a drain on our time. And I think these lazy stereotypes are extremely dangerous. And all it does is it's just propagate the feeling that there is in this country, I'm afraid to say, of the white race is superior. We have white privilege, white middle class, often male, are the people who run this society, from government down to institutions and to the health service. So it's a really difficult thing that hasn't been addressed, and it's just something that has been labelled in this sort of syndrome, Mrs. Bibi, Mrs. Begum syndrome. Oh, it's just another Asian woman, she's just complaining. There's nothing really wrong with her.
So what kind of change do you want to see with this?
So I think what we need to do is, first of all, highlight that this thing exists. I'm sure that lots of people listening and watching will not even have heard of this syndrome and be totally unaware of it. So highlighting that it exists, and B, recognising that and saying, well, if this does exist, what can we do to tackle these stereotypes? What can we do to tackle these ingrained prejudices that certain people complain more than they should, and they are just a drain on our resources? And I'm sorry to say that Asian doctors, I've heard this myself from people I've worked with, are also prone to fall into this trap of labelling people with these lazier stereotypes, these prejudices, and just to agree with their white counterparts that, oh yeah, well, it's just Mrs. Begum, she's just complaining, there's nothing really wrong with her. And I think what we need to do is understand that it's an odd position that we find ourselves in as ethnic minority doctors. We're sort of immune to that because we're in a privileged position, but it's as if we should be grateful for having been granted that position, that, oh, well, we've been allowed to practice medicine, we're the privileged middle class. And so, we should just parrot and mimic what our colonial masters and previous overlords used to say.
I'm just thinking about the word laziness. It is lazy of us as ethnic doctors to just sort of brush that away.
Yeah.
Because it is a complex problem. Pain is a complex problem, particularly our culture. Our culture is very complex.
Yeah.
Because of generations and generations of trauma, essentially.
Absolutely, yeah.
And I think what's important is the awareness, isn't it? It's sort of stopping and realising that we can't just brush it under the carpet and just take it lightly. But the question is, are we more responsible about this because it's our culture? Do you think the shortcomings is from us? I mean, that's what it sort of feels like.
I'm not quite follow that.
So the onus is on us to change this stereotype.
The onus is not on the victim of the stereotype to change the stereotype.
Right.
The onus is on those who propagate the stereotype to understand and accept that it is a stereotype, and then to make amends for it and to ensure that it doesn't happen, because implicit bias is a big thing now. It's very fashionable and it exists. And sometimes perhaps subconsciously the doctor is doing that without realising that they're doing that. And they're not taking that thing on board. But the odd thing, this article that I read about that, this phenomenon, actually the doctors who were displaying this syndrome still oddly carried out investigations and tests and did look at the patient and try and work out what was going on. So perhaps there was an underlying fear that we might be missing something, or we may be sued if we don't do all the tests. So clinically they actually did what was required, but it was just a mental attitude.
So it's like a mindset thing.
A mindset thing, yeah. That they displayed either overtly or perhaps subconsciously. But
this mindset thing is sort of more of a cultural thing rather than a medical thing.
Yeah.
You know, so it's more of a nationalistic cultural aspect.
Yes. Yeah.
Which has a lot of geopolitical,
absolutely, yes,
issues.
Yeah, of course.
And we can talk for hours and hours on the geopolitical issues. But I mean, how do we move forward from this? Okay, we've got this stereotyping, and stereotyping takes a long time for it to develop, or is it a short period of time? I think it takes a long time.
I think it takes a long time, and as you say, there's a lot of cultural and historical baggage associated with this. With the European nations, with their missions and crusades and escapades in foreign countries, where essentially their aim was to exploit those countries of their natural resources. And in order to do so, one of the tools that they employed was to talk about barbaric others, or talk about the uncivilized masses. And we, the great white man, the white man's burden, Kipling, we're all familiar with that. The white man's burden is to civilize these uncivilized, these barbaric others. So I think that ethos is ingrained in the psyche of this nation, and European nations perhaps generally, but we can speak about the UK because that's where we are. So,
but also our nations as well. Even Iraq. I mean, we had this mindset that the white man is more intelligent than us, is more civilized than us. Yes. And that's not a new thing. It's been going on for generations and generations, and actually changing that mindset takes a lot of self-awareness.
It does, and I mean, this is perhaps a topic for another day, but decolonisation is a movement that is taking root and is growing. So we have to first of all decolonise ourselves and our minds to understand that we are not inferior to these people. It's an accident of birth, an accident of ethnicity, that we have a darker skin or we have a different culture and a different set of values and ethos. And there's no less inferior. In fact, the civilization started in Babylon, current day Iraq. That's where most people accept that modern civilization began thousands, millennia ago.
And then different civilizations sort of evolved in sort of different areas, and everyone went down different paths.
Yeah.
Do you think this kind of mindset, this inferiority mindset, has seeped into the medical
I think so,
profession?
Because even if we talk about India, where I'm from, where my family are from, my dad.
You were born here.
I was born here, essentially. Yes, I was 6 weeks old when I came here, but to all intents and purposes, I was born here, lived here, went to school here, trained in medical school here. But my dad trained in India, came here in 1975 as a young doctor. But even in India and Pakistan, the whole medical curriculum is taught in English. So there is this mindset that unless and until we learn English, and our medium of instruction is English. I don't know about Arab countries, but
same thing. Iraq, the same thing. It's all taught in English. And even there, I mean, when I went and talked there, this mindset is, yes, British is best, Iraqi is not. So it was always going towards the kind of UK. That's where the the real Mecca is for medicine, Mecca of medicine.
So I think there's two things. One, and this is the harder thing, is to address and combat the psyche of this nation and to make changes there, which we perhaps can do by educating our peers or our juniors at medical school and teaching them about cultural diversity, multi-ethnicity, the sort of society that we live in. But two, which is more important and perhaps easier, is decolonising our own communities, making our own societies aware, whether it's Iraqi or Indian or Pakistani, that look, we have our own rich culture, we have our own heritage that we can draw upon. Ibn Sina, Ibn Rus, all of these amazing polymaths. They weren't just mathematicians or physicians. They were polymaths. Versed in astronomy, medicine, art, philosophy. Huge figures in cultural learning. And the Renaissance only existed because of the learning that the Arabs brought from Greece, from ancient times, and then added to and expanded upon hugely in Muslim Spain. So these figures that we can draw upon as a start, and then going back, looking at what our heritage is, what the Prophet taught. Islam and science are not irreconcilable. They are not diametrically opposed, as perhaps people think Christianity and science are. So we have a huge cultural background that we can draw upon.
Have you always had this kind of view, or has this developed over...
Well, it's developed, I think, to be honest, it's developed over time. Since I was a young teenager, so maybe 11, 12, 13, I remember this instance so clearly, vividly, as if it were yesterday. We were in the Tower of London, wherever the crown jewels were kept at that time. And it was me, my mum and dad, and my sister. And my mum said, it was a summer holidays, crowded room. And she pointed to the crown jewels and said, you see those jewels? They are from Hyderabad, India. This is the city where we come from. I was 11 years old. I was hugely embarrassed. I was turning red and thinking, Mum, why are you saying this? And then afterwards, we had a discussion at home, which was saying, look, these resources have been appropriated from our countries, our nations. So since the time I was a young boy, I've been instilled with this value and this ethos that, look, where did this nation come from? How can you call yourself great if your greatness is based upon the exploitation of others? And your resources and these beautiful buildings that you've built. I mean, the Tate Museum, that was Henry Tate. He was basically a pirate and a terrorist. We know about the sugar farms and how people were treated to farm sugar. They had their limbs cut off, all sorts of unbelievable mistreatments. And he built a massive museum of art. Wow, what a philanthropist, what an amazing guy. But where did that come from? Where did his wealth come from? So this thing has been instilled in me since I've been young, and when people hear me talk about it, they think this guy's weird. What is he going on about? Why is he talking about these things that happened decades, centuries ago? But if we don't know what our history is and where this thing has come from, then how can we possibly recognise it and B, act against it when we see it?
And given that a lot of medical practitioners are Asians and sort of non-Caucasians, and that's unlikely to change as well in the near future, particularly with Brexit around the corner. They need even more help from
absolutely. That's
from surrounding neighbours and countries. I mean, how can we move forward with this? I mean, you sort of gave us a few tips on this, and it is a mindset shift on our side. And I think for me, it's just being more courageous about your culture and about your past and about what your ancestry is about and getting your voice out there. I think that's really important. But it's a difficult issue. It is a difficult issue because a lot of people out there say that the GMC are racist. Or, racist in the sense that people of ethnicity or minorities are discriminated against, or if they are being investigated, it's you're disadvantaged. So I mean, there's been lots of evidence that's shown Asian, Black and ethnic minority doctors are referred more often to the GMC. What they're referred for is often non-clinical, so social or other issues where they can't mount a defence saying that, oh, well, I didn't do anything that was out of what normal practice was. So often weird and sort of esoteric reasons that they're referred to the GMC. And even when they're referred, and say there was a white doctor who'd been referred for a similar thing, the sanction against the ethnic minority doctor is often greater and more punitive. I mean, the huge case that we know about most recently in the last couple of years is Bawa Gaba. A pediatric registrar who was covering 6 wards, covering the consultant who was not there, covering the SHO, dealing with a very sick child,
and the vitriol and the hate that was propagated, particularly by the Daily Mail, an absolutely abhorrent publication, and the pictures that they portrayed of this sweet-looking child. I mean, first of all, I want to clarify that it's extremely sad that this young boy died and suffered this untoward clinical incident. But the way it was portrayed, the Bawa Gaba is severe, harsh-looking woman, black woman in a hijab versus this sweet-looking child, and the extrapolation and the difference that they showed in these photographs. And there was a clear agenda behind it. The right-wing press were clearly pushing this agenda that this Nigerian Muslim doctor, actually trained here in Leicester, let's not forget that, she's culpable for this, she should take the blame. And the GMC and the MPTS, Medical Practitioners Tribunal Service, they fell into line with what the right-wing press and the right-wing establishment wanted them to do.
So it's fear. Fear sells.
Fear for themselves, fear for not seeming to uphold what mass hysteria, which could have resulted, what that might result in, what the outcome might be if they weren't seen to act against this foreign doctor who obviously was clinically negligent, and there was nothing to do with the fact that she was understaffed, under-resourced, and had no one to help her dealing with a sick child and all covering all these other wards as well. That, of course, that wasn't relevant.
But it's created these dialogues that we're having now. It's created other movements as well here in the UK and even worldwide. And I think that it's one of these examples where disasters do lead to change.
They do, yes. I mean, I was amazed and heartened to see the response that there was a massive crowdfunding campaign for her legal campaign. And it was led by white doctors. Let's be honest. It was led by white doctors who said, "Well, this is not right. Let's look at this objectively and see what the situation was, and how can we possibly punish someone who had to work under such undue stress, such circumstances that we wouldn't hope that anyone would have to work under." So that was heartening to see. But that was one response to one incident. I think the psyche and the mentality that is underlying and pervasive in this society, and you mentioned Brexit, it's only going to get worse. Racism, xenophobia, particularly Islamophobia, these sorts of things have been and are rising on a daily basis. We see it everywhere, portrayed, whether it's this poster that Nigel Farage put out of floods of brown people swarming this country, or the pronouncements by Boris saying, if you come over here, across the channel in a boat, you'll be sent home. I mean, what kind of humanity is that? The most vulnerable and this destitute sort of population, immigrants, you're going to send them back to die. What kind of attitude is that?
It's not easy. It's not easy, and I think fear and ignorance are the underlying problems here. And the only way to sort of counteract this is to talk about these things and create policy change. I think that's the only way forward. And words are very powerful. Particularly racially connected words as well. I think that's still a bit of an issue. That it's not talked about enough. Racially sensitive words. It's sort of interesting. And given that we are in a multicultural society, we can't deny that.
No.
We can't say that we're all just one particular paint.
Absolutely. And there was an old Mercedes ad, and it used a song, "If everybody looked the same," I can't remember the song now, but basically it was saying, if everything was the same, if every Mercedes was the same, wouldn't it be a boring world? And it's the same with people.
I thought all Mercedes looked the same.
I don't know. But
I'm
anyway,
into Mercedes.
I
mean, it's we need to find a way of sitting together, working together, eating together, and getting rid of the bad apples, essentially. And I think it's the bad apples that mess everything up.
Yeah, actually, it's interesting. It reminds me of a quote of Muhammad Ali on Parkinson, and Michael Parkinson said to him, "Well, surely not all white people are bad." And he said, "No, of course not." But he said, if you had a basket of apples and there was a snake in there, a poisonous snake, would you put your hand in there? And he's saying, no, of course you wouldn't. So he's saying, look, that's the same thing. If there's a small minority of people who are poisonous, how do you know which ones are okay, which ones are not? So, it's difficult. It's difficult, but I think dialogue is important. And if we...
Dialogue is really important.
Yes.
And also on the Asian and on the ethnic side of things, we need to change that mindset as well.
Yeah.
That we are rich in everything, essentially. We don't have to get rid of our past, so to speak.
Absolutely, yeah.
The more we embrace it and are able to integrate and are able to... I know some people have negative connotations with assimilation, but I think if we can have our own and assimilate with the current, I think that would be a good thing.
Yeah. And, the thing that saddens me is that I think my kids are going to have trouble and struggle speaking Urdu, our language. I struggle with it as well.
Yeah.
So this is a mindset, and, like I said, it affects all of us. I think it affected my parents when they came to the UK in the mid-70s. There was still of that mindset that we must teach our children English. Our language is sort of secondary. So I do speak it, but I'm not fluent in it. And so my kids are going to be even less fluent in Urdu, the language that...
So maybe the onus is on us to be more rich in our own culture,
absolutely.
in our own language, in our own heritage and ancestry. And that way we understand the weight of what we have.
Yeah.
And then we can use that to contribute to current society.
Absolutely.
Maybe that's something to think about.
If you take away a man's language, you take away everything that is his. The cultural history, the literature, the poetry, art, philosophy, all of these things that we don't have access to. There are huge reams and reams of knowledge that we just cannot avail ourselves of.
And coming back to a more positive sort of aspect of we're coming towards the end of this episode, is that we're bringing this metaphysical aspect of our existence into ourselves, which is the culture and the heritage and the language that we have, and then packaging it into the 21st century to allow our patients to get better. And, lifestyle medicine is the next big thing now, isn't it?
Yeah, of course.
And, that's what it's about. If we're able to bring our heritage and the current problems that we have, bring it together, the physical and the metaphysical, make it into a lifestyle-like medicine in the 21st century, I think that's a good thing.
Yeah, and I think only more people will benefit.
Yeah. Bring everyone together and having these dialogues of difficult topics. It's not easy hearing these words: white, Asian, Paki, Arab, whatever. These kind of they're very emotive words. But we need to have these dialogues in a relatively civilized discussion.
Yeah.
Rather than turning it into something that's violent or physical. Any last pointers, Dr. Suhail, before we say goodbye to the viewers and the listeners?
I think basically it's just understanding that at the end of the day, when we all bleed, our blood is the same. It's still red. It doesn't matter what the colour of the skin on the top of it is. We still bleed the same blood. We're still humans. We still share the same humanity. And we still have pain and suffering and joy and happiness as well. And we, all that any one of us wants to experience, whether that's here in the UK or in Iraq or in Palestine or in India, we just want to have a happy, peaceful life and get on with what we can do with our families and our loved ones. I think that's, if we understand that and try and live by that, I think the world will be a better place.
Thank you so much, Suhail. Thank you for having me. Thank you. Good.
Thanks for listening to this instalment of the Surgical Spirit podcast. For all the latest in the world of surgical spirit, don't forget to follow on Twitter at The Third Eye Doc and catch me on Facebook at the page The Third Eye Doctor. You can visit the website at www.thethirdeyeDoctor.co.uk for more information on the work that I do. And please send us feedback and questions and suggestions for the podcast. It's always a pleasure to hear from you. I've been Dr. Haidar Al-Hakim, and I'll see you next time.